evening, everyone, and welcome to tonight's Research Tuesday, Ice Storm. I'd first like to acknowledge the Kaurna people, the original custodians of the Adelaide Plains and the land on which the University of Adelaide's campuses at North Terrace, Waite, Theberton and Roseworthy are built. My name is Julie Owens and I'm the Pro Vice-Chancellor Research Strategy. Tonight we're looking at ice addiction, a problem which evidently concerns many in the community, as is clear from our full house this evening. We're going to hear from three experts in addiction. First, Dr. Femke Biesman-Pelman, then Associate Professor Linda Gowing, and Associate Professor Robert Ali. Now, first they'll present individually, sharing with us some background information about ice as a drug, the biological side of addiction, and the responses that can be offered both now and in the future. Now, following the presentations, all three speakers will join me for a panel discussion in which we can delve a little deeper into some of the issues surrounding ice addiction. And then we'll invite questions from the audience as we'd like you to get involved. So, to kick things off, let me first introduce Dr. Femke Biesman-Pelman. Femke is a behavioural neuroscientist with a strong interest in the neurological basis of individual differences in behaviour and mental health. And she works on the intersection between psychology, physiology and behaviour, and has proposed a new theory about the effects of early life experiences on the developing brain and the impact this has on later drug use. Now, she is the director of the online Master of Science in Addiction to Studies degree that we teach with King's College London and the Virginia Commonwealth University. She also leads curriculum development of the university's addiction studies in our Health and Medical Sciences degree. And she has also developed a free online course on managing addiction with the two other presenters. So I call on Femke, please.
Thank you all for coming this evening, despite the quite horrible weather. So I'll start introducing the topic, and I'll mainly talk about who uses ice, what does it do, are we really having a meth epidemic, why do people get addicted and why does not everybody get addicted, and this basically opens the discussion to see these are the adaptations with repeated use. What do we need to treat when people are getting into trouble with drug use? So in the media, everybody agrees there is a big meth epidemic. But if we look at the data, the people that work in the addiction field don't feel exactly the same about it. There have been changes in meth use that I will talk about a little bit later. But I first like to show you a little bit about the image that meth has here. And people really notice these images, they really stick in our mind. The impact that meth has on a perfectly healthy person that might have a very promising future, and how that life can change quite quickly or dramatically, and that their prospects really change. This is another example of somebody who started using meth, who deteriorated. Meth use and addiction in general is of all social layers. This is, for example, Harriet Wren, the daughter of the former New South Wales Premier. Luckily, she did manage to get out of this. So this is what I want to show is addiction is difficult to manage. If somebody has really gone down the path to develop an addiction, it's not easy to just step out of it. That doesn't mean it's impossible, it's just hard work. So when we look at methamphetamine, it's a stimulant. It's a central nervous system stimulant, and it gives you a lot of energy. It might give you an ego boost. It's mostly smoked and injected, and these are methods of using a drug that give a very quick effect. And we know that drugs that give a very quick effect are usually get you addicted more quickly because they are reinforcers, and the time between the action of taking a drug and the positive feeling is very short, and your brain quickly learns, let's do that again. It's based on affecting the dopamine system in the brain. So methamphetamine is a very smart releaser of dopamine. It has a triple action where it gives a very strong release of dopamine. So it increases your energy, but it also gives a high feeling. When you have a high concentration, you also can get, for example, high heart rate and agitation. People that use meth can use it, they might not use it just once and then enjoy the effects, but they might use it in a binge pattern where they keep using it to keep going, and that really exhausts the body massively. And when we look at the quick ways of using the meth, we see that the effect really takes place within seconds, and that's really one of the things that users enjoy about it, but that does add to the addiction potential of it. When we first look at is this really a meth epidemic? Is this something we haven't seen before? When we look at the data from people that are 14 years and older from the Australian Household Survey, we see that meth use or amphetamine use actually has gone down a little bit. And when we look now at the different age groups, we can see that it's most prevalent in the group that's 20 to 29. So it's not actually the young kids that are using it. It's often people that have a bit more money and that might be using it to manage shifts and that sort of thing. And again, in this age group, amphetamines and methamphetamine use in general has gone down. So that's a good thing. And the comparison to S3 is always important, that amphetamines are a problem, but it is nothing compared to alcohol and smoking. If we compare recent use and for alcohol, for example, it's around 80%. So that's always important to keep in mind that meth is causing a problem, but it is one of the problems. The main form of methamphetamine has changed, and this is something that is worrying. So we see that the use of crystal meth or ice has increased, and that's what people are talking about. That's the meth epidemic that they're talking about. This is a much more potent form of amphetamines, and that's why it's can get people addicted much quicker or get them in trouble much quicker. So I've been using drug use and addiction a bit, I've been changing it around. It's very different. There's a lot of people that can use alcohol and other drugs sometimes or regularly that don't develop an addiction. Addiction can only develop with repeated use because it's basically the body getting used to the presence of the drug, but also it changes the way we perceive, decide, and it focuses our attention on finding the drug instead of the full array of activities that we do. So we see that somebody that has developed an addiction we see one of the main things is compulsive drug seeking. So for me, something that separates drug use from addiction is really the loss of control over how much somebody uses it, how much time they spend on using it. And the video that you just saw is a nice introduction to that. We use that in the teaching that we do. For example, the free online course that we've developed, we use this kiwi, the flightless bird, to show that you might be able to imagine that a bird tries the golden nugget once and it likes it, but it can't stop searching it, although it's not having the same effect anymore. When we look at an addiction cycle, we distinguish 3 different phases. The first one is the binge or intoxication phase, and it really, in the brain, regions are involved that give euphoria, that give pleasure. It's about reinforcing and being motivated to get that again. The second phase is around withdrawal. So we see that if somebody has been using, for example, smoking, even nicotine regularly, their body gets used to having it around, starts to adapt and starts to counter that effect. So if somebody doesn't keep using it, the body is basically showing withdrawal symptoms. So the drug use starts to change from, I'm doing this because I like it, to I'm doing this because I want to avoid withdrawal symptoms. So that's already a different phase of drug use. And the last one is also around craving. Craving can be very strong in people that are regular users and that haven't used for a while, but also for people that have stopped using, and that it might trigger relapse, for example, even after years if something happens and they are reminded of the place where they always used to use. craving is a very physical urge to use again. We know that each stage also involves different biological pathway, and I'll give you a little snapshot in a minute. But the transition from binging or enjoying a drug to addiction can only happen with repeated use. And it really involves neuroplasticity in the brain, so adaptations due to repeated exposure, that addiction really takes shape. So this is something that I'm not going to talk to very long. I just want to illustrate that addiction is characterized by a lot of changes in the feelings that somebody has, how they see the world, the decisions that they make, how they choose short-term over long-term gain. And there are a lot of different brain systems that are involved, and they are involved, as I mentioned, in the different stages of addiction as well. So it starts with an activation of the dopamine system, but it goes far, far beyond that. Now, my interest is very much in susceptibility to addiction. So a lot of people use drugs at some point in their life, but most people don't develop addiction. So why is that? People differ a lot. If we look at this room, if you imagine the first time you tried to smoke nicotine or you had a drink, we all experience the drug effects differently. Some of us might be more impulsive, so we already started using very often, or might have started using other drugs already. Others might be really good at thinking about, oh no, I'm not going to do that because in the future I might regret it. We experience withdrawal very differently, so some people might be able to use it and then walk away without anything, while other people might have a very strong craving to use it again quite quickly. We also see that relapse is very different, so some people are very, very sensitive to stress-induced relapse. For example, around exam time, a lot of ex-smokers relapse because of the added stress, and the smoking is, for example, a coping for them. Unfortunately, there's also individual differences in response to treatment. We know that there are, for example, genetic differences in whether people respond well to treatment, but also do you have a lot to work with? Does somebody have other coping styles, or do they really fully rely on the drug to do this? Because if you then just take away a drug, you're not going to help them in the long term. So biological, psychological, and social factors interact to provide both risk and protective factors, because luckily it's not all negative. My question is always really, why doesn't everybody become addicted? Because the system that drugs target are so fundamental to our normal functioning that all animals have it as well. So we see that there are biological, psychological, and social factors that influence first whether somebody uses illegal drugs, for example, in the first place, but also the changes that then take place and whether an addiction develops. So when we compare two risk profiles of individuals, on the left, for example, first, somebody might have some biological protection. They might have enzymes that slow down how alcohol is broken down, and they might feel very, very poorly if they drink a lot. So that's more like a natural boundary setter already. They might have very strong coping styles. They might have a very strong network. They might have some protective factors in that area. And they might have some friends that introduce them to drugs. That's not so great, and they might even say, oh, this is all normal, and we expect you to do this. So there's some pluses and minuses here. So they might use drugs, and there is a chance that they will develop addiction. When we compare it to the person on the right, they might have genetic predispositions that make them very strong respondents to the pleasant effects of drugs, not have many side effects from the drugs. They might not have a lot of other social skills, or they might not have a job. They might have friends that say, oh, let's just try to have a healthy lifestyle. So there's lots of risk factors in this person's life. So when they use drugs, they might or might not develop addiction, but the chance that they will get into trouble with it is much bigger. And if you look at this picture and you think, oh, I want to treat this person, I want to help them manage their drug use more effectively, this person on the left has much more to work with. You can increase those areas that are protective, but the other person you first have to start thinking, do I even know anybody who doesn't use drugs? Do I have a network, or when I've stopped using drugs, do I alienate all my friends? That really is a different story if you think about how easy it is to manage an addiction. So when we look at the impact, I think it's important to always emphasize, and I'm sure you know that drug use doesn't only affect the person itself, it affects the family, the parents, maybe the kids, but also the colleagues, people that might be at risk. For example, if somebody is using, truck drivers might be using on the road and might be causing hazardous situations. The whole community is affected. And I think some of the worrying images that we see in the media are about whole towns that are being affected because there's not a lot of job prospects and a lot of escape behavior in this. And it's a dangerous place to go in that respect. As I mentioned, ice is a very strong reinforcer, but addiction develops over time. So it's not that with one-time use you will be an addict. That's important to reinforce because it opens a window of opportunity to intervene. So we can identify people that are at risk, and that opens an opportunity to give them information about options that they do have to manage their use. Not everybody wants to stop. There's a whole range of information that Linda will be talking about this is where a person is, they're motivated to go in this or that direction, and we have a lot of opportunities to help with that. So importantly, we need to match the response, the doctor's response, the public health response to what they need, because if we're just going to push something out, the effect is not going to be very, very big indeed. So if you want to learn a little bit more about my research, you can watch this ABC Catalyst section on addiction, and the links will be sent out as well. And as I mentioned, the University of Adelaide let us develop a course on managing addiction, which is a completely free resource that discusses what drugs are, what addiction is, and talks about a lot of the things that we're talking here. So if you're interested in learning a little bit more, it's an edX course, and we will send that link out as well. Thank you very much.
Thanks very much, Femke. Now, next we'll hear from Associate Professor Linda Gowing. Linda is an Affiliate Associate Professor in the discipline of pharmacology. She's been working in the area of evidence-based practice in the treatment of addiction since 1998 and has substantial experience in the preparation of systematic reviews of the literature and the evidence around this area, including Cochrane reviews, the international gold standard for these, and evidence-based guidelines that really inform practice and approaches. She's also involved in teaching in the area of addiction as course coordinator in the Master of Science in Addiction Studies and as a presenter in the free online MOOC that Femke just referred to, Managing Addiction. Linda.
Thank you.
No, that's fine.
What I'm going to talk about is some of the different types of interventions that are available. And we've found it useful over the years to put these different interventions onto a framework that thinks about the biological basis of addiction and looks at how those different interventions fit in the different stages. And this graphic represents our most recent portrayal of that framework. This rather pretty version is one that we produced for the free online course that Femke just mentioned. And what we're looking to get the message with this version, which we've called the recovery pathway, is to get the idea that it takes time for drug use to go through the stage of misuse and become dependence, and it also takes time to recover. Femke has referred to this a little bit already, of talking about the fact that a single use of any drug, including ice, does not result in a person being addicted. It takes a period of time of regular use for those brain changes to happen and for a person to actually meet the criteria of dependence. So that's where the first type of intervention comes in, that if you can detect people who are using before they have become dependent, then you have a chance through that brief intervention of providing them with a degree of insight into the reasons why they are using drugs, what the consequences of their drug use is, motivating them to think about the benefits of reducing or stopping, and basically encouraging them to go back up this pathway and not to progress down through dependence and into the problems. Brief interventions do also have some relevance for people who are dependent. If you can identify people who are dependent, the aim of a brief intervention is a little bit different. The aim then is not so much to encourage them to take action themselves to reduce drug use, because the brain changes that happen with dependent make that very, very difficult. So what you're looking to do with brief interventions with people who are at least at high risk of being dependent is to encourage them to engage in structured treatment to address that dependence. People who are using drugs and who are possibly dependent, and their families, both would like to think that all you need to do is to detox. Just stop using and it'll all be fine. The reality from evidence and from experience is that because addiction has both psychosocial and physical dimensions, it's not that easy to just stop. And people who go through managed withdrawal, if they don't then go through other treatment components, relapse is very likely. That's actually what this little line here shows. I just haven't put the words relapse in. Managed withdrawal addresses only the physical elements of dependence. It removes the drug from the system, but it does nothing to deal with the cravings, the adaptations, the psychological dimension of dependence. And that psychosocial dimension may comprise both issues that have led the person to use drugs in the first instance, and also the consequences of a drug-using lifestyle. So the recovery pathway needs to have a whole lot of different components, things that address these psychosocial elements and enable a person to work through towards recovery. Femke has given an example of a person who has a number of risk factors and very few protective factors. So this is a person who may have very poor living skills. They may not have completed much in the way of education. They may not have any employment experience. They may have spent time in prison as a result of their addiction. So they don't have very many resources to help them sustain recovery. So for people who have really been seriously damaged, either as a result of disadvantaged upbringing or perhaps as a result of their drug-using lifestyle, they need to develop those living skills. These sort of interventions are things like residential rehabilitation, for example, therapeutic communities, which may help them with their socialisation skills, as well as learning how to adapt to a drug-free lifestyle. You need to be quite committed to go through residential rehabilitation. It can involve 3 or 4 months at least of living away from your general community. And so, of course, for people who have work or family commitments, that's maybe not the option that they would prefer. But for people who are seriously damaged and who need to develop living skills, that's a good option. The relapse prevention option is helping people to identify the cues that might cause them to relapse or that might cause them to feel strong craving. So this can be things, for example, it used to be the case that people who drank alcohol would often smoke cigarettes as well, tobacco. So for them, a really strong cue was if they went to a pub and had a glass of beer, they would immediately feel a very strong craving for a cigarette. We've got tobacco smoking quite well under control. We haven't finished yet, but that is not quite such a typical situation anymore. But you would want to do the same with an ice user. What are the situations in which you might feel strong cravings, you might be at risk of relapsing, giving them an awareness of those risk factors and helping them come up with strategies to deal with them. So these sort of relapse prevention techniques, these are often things like cognitive behavioural therapy that might be delivered by psychologists that's helping them to come up with ways that deal with those cravings. Medication may also be used with relapse prevention, and Robert Alo will talk a little bit more about medication options and just what we do have in our kit bag or might have in our kit bag in the future for methamphetamine. The last circle that's up there is support. This really encompasses a whole range of different possibilities, including family networks if they have it, but it's also things like the self-help groups like Narcotics Anonymous, and also Smart Recovery, which is another mutual support organisation that's available. So those are quite a cheap way of providing support for maintaining abstinence. Yep. I think that's all I need to say about support. The most important thing is to keep remembering that recovery takes time. There is no miracle cure to addiction. It takes time to develop it, and it certainly takes time to recover from it. Indeed, I think people who've been dependent may well always be in recovery as opposed to cured. This slide makes the point that for a lot of people, withdrawal is very difficult to complete. The brain changes that are part of dependence and the strong cravings that often are associated with progressing from drug use to abstinence mean that people find it very difficult to complete withdrawal. With a lot of drugs, we have the option of substitution treatment. With tobacco smoking, there are nicotine patches, nicotine inhalers, nicotine gum. The concept of substitution treatment is that you're providing people with the drug of dependence or with a drug that acts like the drug of dependence, but in a way that is associated with less risk. The risks of tobacco smoking are to do with the act of smoking. It's the carbon monoxide and tars that you inhale along with nicotine that causes the damage. So if you can provide that nicotine without the carbon monoxide and the tars, you can reduce cravings, you can maintain the physical addiction and give them time to deal with the psychological dimensions. Similarly, we have substitution treatment for opioid dependence. The harmful effects of heroin and other opiates are to do with them being injected and also to do with the uncertainty of dose that they're receiving. So if we deliver an opiate to them without those risks, you can give them time to stabilise physically and deal with the psychological dimensions of addiction until they feel ready to withdraw and have the resources around them that enable them to withdraw successfully and progress towards recovery. At this point in time, we don't have substitution treatment for amphetamines, and that's something that, again, Robert Aley is going to talk about a little bit more. So that's it from me.
Thanks very much, Linda. So finally, I'd like to introduce Associate Professor Robert Aley. Robert is a public health physician and specialist in addiction medicine who is passionate about training professionals in the field from around the world. Unsurprisingly then, he is director of the World Health Organization Collaborating Centre for Research into the Treatment of Drug and Alcohol Problems at the University of Adelaide. He only recently retired from his position as Director of Community-Based Treatments at the Drug and Alcohol Services South Australia. He's a member of the Australian National Advisory Council on Alcohol and Drugs, a member of the Cochrane Alcohol and Drug Editorial Board, the systematic reviews I referred to earlier, and the WHO Expert Advisory Panel on Drug Dependence and Alcohol Problems. We're very grateful that Robert has come along tonight to talk. Thank you, Robert.
Height adjustment. What I'd like to do is to talk to you about where we are now, where we're heading in the future for the treatment of methamphetamine addiction. And I want to start that by providing a conceptual framework which has been glanced off by the two previous speakers, but I want to crystallise this as a different way of thinking about the problem. Most people are here because of concerns about ice addiction, either the risk of becoming addicted or responding to people who have that problem. But as Linda has pointed out, it's not the only problem that occurs from using drugs. And in fact, the vast majority of problems we see in our community relate to problems associated with intoxication, and then less commonly with regular use, and then far less commonly with dependence. The reason why dependence has become crystallised as a concern is because it is so visible and so distressing, not only for the individual, but also those that are directly connected to the person who has the problem. But in our community, we see people who have problems associated with just single use or regular use. And in the case of methamphetamine, it's a drug which is often used to actually enhance performance. So the person isn't intending to get the enjoyment from the use of the drug, they're using it for the functional point of view of giving them stamina and endurance. Now, whether that's to stay up late, to be out with your friends socialising, or reduce the consequences of drinking a lot so you feel less intoxicated, but it has a purpose. And that functional use is often associated with problems associated with intoxication that we're seeing in a variety of areas, whether it's from police being asked to see people who've become aggressive or violent, or whether it's because we're seeing people who are drug driving. And in fact, now the single biggest drug that's detected on our roads is methamphetamine. Those problems present opportunities for intervention and care. And the first area that I want to talk about is the idea of screening for people, looking for people who may be using drugs, but we may not actually identify themselves as drug users. Now, general health and welfare settings represent a great opportunity for intervening, and we've been working with the World Health Organization to develop a screening instrument which is quick, easy and effective at identifying people who have low-level problems and then responding to those problems in a way which helps them reconsider whether use is a good idea. And particularly if the reason that they've attended those settings happens to be related to their drug use, it's an opportunity for a natural conversation about rethinking what they might want to do. It's cheap, it's easy and effective, but most health and welfare agencies haven't wanted to ask the question because they haven't known what to do with the answers. You don't want to start a conversation where you're feeling you might actually make things worse. So the nice thing that we're doing at the moment is collaborating to develop a self-directed learning tool, which is on a tablet or a PC or can be downloaded as a smartphone application, that somebody can do their own assessment, make sense of if they've got a problem, and we'll direct them on the next steps forward. As Linda said, however, if those problems are more serious, then help is at hand and they may need a more intensive intervention. When we first did the validation study, which was a multi-country study that we coordinated through the university, we were looking at all drugs to see whether or not it was effective in identifying problems and doing something about it. And the interesting thing here is that you can see both the control group and those who had the intervention both got better. In the control group, all we did was ask the questions, just ask them to consider their own personal drug use, and that had a dramatic effect on their continued use of the substance. But it was a statistically significant, more of an effect for those who also had that targeted linked intervention. Now, we've moved on from this original study and we've refined and updated our methods of intervening, and that's something that we're about to start as a clinical trial, and we'll be doing that initially at the Royal Adelaide Hospital, where people will be able to consider their own use and look at whether or not they want to change that use, and we're going to follow them up over time to see what impact this simple intervention has in that target population. We're doing a similar approach for primary healthcare activities, and so we'll have a smartphone app also for general practitioners to use in helping people who identify low-level problems. One of the main barriers about not knowing what to do is not knowing where to get help, and so the university has been working on developing a portal. The Commonwealth Government has funded us to develop this portal, and we're about to launch that. And it's a self-directed learning aid for people who see people with drug problems about how to respond, particularly around methamphetamine. We're just shooting video segments at the moment, which we're doing in collaboration with the University of Wollongong. And once those segments have been refined and finalised, we'll then be disseminating that on responding to ICE. So this is assisting with ICE. One of the things we've also wanted to do is to look for safe and effective medications, because medications have been the platform that we've used for treating most addictions, but we've been particularly unsuccessful to date at finding a candidate medication that can work with methamphetamine. We commissioned some work looking at treatment options, and that review identified a significant number of studies. In fact, since the time of that review, the number of studies has actually increased. There are around 18 to 20 candidate medications that were seen to be potentially useful in the treatment of it, but unfortunately none of them stack up with sufficient evidence. And part of the problem has been underpowered studies done infrequently looking at unusual populations. And while some of those medications appear to potentially be helpful in the future, it's the functional agonists that I want to concentrate on in particular. Now, those are medications which have similar properties to the drug on which you may be addicted, but they don't have the strong reinforcing properties that that addictive drug does, and may actually help stabilise your life and help you feel that you're in control and can then receive the counselling that you need to help make lifestyle changes. We've been successful through the National Health and Medical Research Council in collaboration with colleagues from the University of New South Wales in getting funding to do a study on one of those agonists. And the one that we're going to be investigating is lisdexamfetamine. It's an interesting medication. It's currently used for ADHD, but it has never been used in the context of treatment of dependence. We've done some preliminary work which shows it is potentially useful. The reason this is a good medication is because it's what we call a prodrug. That is, the medication doesn't actually work properly unless you ingest it in the way in which it was intended. There are enzymatic changes that liberate the medication and help it to work on the brain. That means that it's got a relatively low abuse liability, and it also doesn't create those options and risk which communities genuinely are concerned about with these types of medication developments. We're hoping to get this study started in November of this year. We're currently putting our ethics application through the process to get permission to conduct the study. But we'll be doing that both here and in New South Wales, looking to see whether it is an improvement on the current medications, which work for some people but don't work for everybody. Unlike treatments for opioid dependence, where we need very long periods of medication treatment, usually managed in years, the evidence for methamphetamine appears to be that you only need medication for the first few months, somewhere around 3 to 6 months. And that gives sufficient time for us to then work with counselling and other intervention strategies to help reshape and refocus the life. What we do know is that there's a lot of medications that don't work, and these are important to know because these are the kinds of medications that have been tried, and many of them have been found to be unhelpful, but importantly some of them have actually been found to be dangerous, either through side effect profiles or risks of actually creating a bigger problem than we originally had. And of course, there are many examples in the medical literature where we start off with a good intention, but it turns out to not be as successful as we would like. Hence the reason for us to do these very important clinical studies to make sure that we're actually on the right wavelength. As Linda said, medication's important, but it's not the only component of the answer. There's biological aspects, but there's also psychosocial aspects. And counselling interventions are critically important in helping reshape commitment and determination to change things around. We've actually learned a lot about psychosocial interventions in the methamphetamine area, but we've also learned a lot about how the brain chemistry interferes with what I would call executive decision making. That's understanding when something isn't a good idea and deciding you're not going to do it. Sometimes we see things that are not a good idea, but we decide, well, we're going to do it anyway. So we've done a risk assessment and we've decided, no, we think the reward is worth the risk. Methamphetamine has a way of interfering with the frontal lobes, which are those areas of the brain that tell you something's not a good idea and you shouldn't do it. It's your adult part of the brain. And unfortunately, meth is very good at getting the midbrain, the part of the brain that says, well, I don't care. I'm going to do it anyway. And it has a way of disconnecting those circuits that actually creates serious risk and harm to the individual. So part of the problem is that when their ability to think has been interfered with, trying counselling can actually be a complicated business about engaging somebody in a thought process where they have to remember what you've said, understood what you've said, and then action that by changing what they do. And methamphetamine interferes with all of those processes. So what we're doing at the moment in collaboration with the psychology department is that we're looking at a different way of presenting information. Normally counselling would be about engaging commitment for change, improving their motivation, and then providing either cognitive strategies or behavioural strategies to help people learn different ways of managing life. This type of approach builds on a concept called acceptance commitment therapy. So this is accepting where you are and making a commitment to do something about it, but doing it in baby steps, in a way in which in the early stages of recovery, the brain can actually connect and make sense of what's being said and make a commitment to do something. So we're still working on motivation, we're still thinking about the cognition, but we're also dealing with people at a different staging. So instead of just one formula, the research trial that we're doing is what we would call phasing and layering. So in the different phases of recovery, they get a different intervention, and as they are able to adapt and adopt this understanding, then we can then layer in the different approaches. So we build sequentially. Expert treatment programs in this state do work. Counselling does work. I think there's a lot of belief in the media that we don't know the solution, we don't know what to do, and nothing seems to work. And that's often fueled by individual stories where recovery has been difficult. And it is difficult. Relapse is common. We know that people who have drug problems can easily be cued back into using drugs again. But it is possible to build a recovery pathway. it requires determination, and it requires a commitment. I think we as a community have to help those people, but we also need to understand the platforms that work in making that journey possible. And this is where integration of treatment is key. Specialist drug addiction treatment services tend to deal with the things that are inside the circle. So it's about planning a treatment intervention, and it's about getting commitment and monitoring change. But these things around the outside, that's the chaos in which the person lives. That's the things that have all become unravelled, whether it's legal problems or it's housing problems or it's family connectedness or mental health issues. Those are the things that really need to be dealt with. And it's very difficult for a specialist drug treatment services to provide that holistic care. And that's why that integration, that connection to other agencies, but also building on the assets the person brings to treatment is important. This has probably been one of the major pivot changes that has occurred. That previously it was seen as just the counsellor working with the individual. Now we talk about the individual bringing their resources to bear. And so in that community reinforcement approach, we can actually help connect those opportunities. The other thing that's important is that not everybody needs intensive care. So we've already discussed how people, before they become severely dependent, might only require a brief intervention. But we can also provide a stepped approach and become more intensive based upon an individual's response to treatment services. That helps spread the treatment resource even further, but it also means that people are getting individual-based care. So, in summary, what I hope that I can say to you is that while it is a chronic relapsing disorder, it is treatable, and we do already have interventions that are working, but we're not standing with those. We're looking at the introduction of new innovations to see if we can provide better treatment connectedness. It's important that our responses are to scale, and while the resources in all parts of the world are challenged, simple, easy, early interventions in primary healthcare and welfare settings, we think, is an opportunity to prevent more serious problems emerging, but also scaling up our specialist treatment responses and connecting to primary healthcare is key. As you heard, I'm an addiction medicine specialist, so my training was in the College of Physicians. We are now going to be part of the Medicare benefit schedule, so general practice can refer to us no differently than they would refer you if you had a heart problem to a cardiologist. So it will be a routine, normal part of mainstream medical practice, and that all comes on board from November of this year. So stepping people into specialist treatment systems will be easier. There is already expert advice within the public health system within our acute care medical services. So at the Royal Adelaide Hospital, there's an in-reach of a specialist advisory service. As that happens, I think you'll find general practice will become more confident in responding to these issues because they know they've got a specialist colleague available to help them. That shared care and step care approach is key, I think, to building a sustainable response to a problem. The big problem of ICE is the fact that it's more potent and its delivery mechanism has a greater reinforcing property. We're seeing worldwide people moving from other forms of methamphetamine to this form. It doesn't mean that the problem is insurmountable, but we do need to address this by community education and awareness and helping those people who have got problems to respond to them in a safe and effective way. Advice is at hand in this state. If you or a loved one has a problem, then you can contact the Alcohol and Drug Information Service for telephone support and advice. They can put you in contact with people in your local community that can help you. And family drug support, because sometimes as family members it can be very difficult to know what to do, how to respond to people who have this problem, and family drug support is an ideal opportunity to assist you in that. Thank you.
Thanks very much, Robert. I'd now like to invite all three of our speakers to take part in a panel discussion, and we'll also then give you, the audience, the opportunity to raise issues and ask your questions. So please come out to the front. Yeah. Perhaps I could start by asking you to perhaps set the scene a little bit more and put this problem in context. So in terms of public health, how big a problem is ice compared to other illicit drugs or indeed to alcohol? And by that I mean Femke showed that the use of ice might be 5 to 10% depending on age demographics, whereas with alcohol it might be nearly 80%. But in terms of the impact on the individual, their family, friends and society at large, perhaps you could provide a bit more perspective?
Well, the big problems that Australia has, and in fact the world has, are the illegal drugs, alcohol and tobacco. They dwarf, in terms of public health impact, all illegal drugs combined. But that doesn't diminish the concern at the individual level to the individual and the family that is going through the difficulties of methamphetamine addiction. Methamphetamine is something that isn't new to Australia, it's just we have a different formulation of it, and so we've seen methamphetamine use for some time. What we are now seeing, however, is a more public awareness of that, and we're seeing a much greater public profile. And that, I think, is because the individuals who are using the potent form of ice are getting into problems early. So we know half the methamphetamine that's consumed now is crystal methamphetamine, and we know that about a quarter of those who use methamphetamine are using it at least weekly. So they're using a very potent form and they're using it very frequently. The mental health consequences of that is potentially quite profound, and certainly in the emergency departments I've seen it firsthand, people presenting with a methamphetamine-induced psychosis as a consequence of their intensive use, which has caused great distress for the community, the first-line people that were called to the house, and the hospital setting and where they're being managed. So in terms of public health impact, yes, it's definitely the legal drugs, but we do see at the individual level great distress and harm.
Perhaps I could throw out an even more challenging question, and that is, you've talked about the change in the form being used, you've talked about some of the newest research on potential replacement drugs, you've talked about some of the soon to occur changes in access to particular support treatments and so on. Taking all that into account, where do you see the problem going in Australia over the next few years, and what might be some of the most critical things we need to do, perhaps change that trajectory?
Well, I think that there are many things we can do as citizens in the community to build resilience and to reduce the risk of uptake of drug use. And we've done some terrific things in Australia around legal drugs. If you think in my lifetime, I've seen a massive change in community attitude towards tobacco consumption, and the rates of use have dropped dramatically, particularly new initiates into tobacco use. The reason I single that out in particular is because if we're looking at gateway drugs, tobacco is the gateway drug. It creates the permission statement, particularly early age of onset of use. It creates a permission context for behaviour around drugs. So one of those things that is changing is access to that. But I think there are other things that we as a community can do, because risk-taking in youth is an important component of normal social development. And if we don't have healthy environments where young kids can enjoy healthy risk-taking, where they've got meaningful social opportunities, then I think we're actually creating an environment of risk for them. So I think there are things that we can do. The federal government will always want to focus on the importance of setting change agenda around media advertising, about creating awareness. But it's actually, I think, it's far more important about what we do in our local communities to create social cohesion and connection, which are important.
Thank you. Perhaps I could ask Femke and then Linda to follow on a little bit from that. I was particularly interested in what you're referring to in early life experiences and so on. I just wondered, Femke, if you could perhaps firstly comment on any particular critical exposures in early life that interact with genetic predisposition and so on that we should be aware of.
Yes, it links really well with what Robert is saying. My research focuses on how positive early social interactions can help shape our brain, our developing brain, and for example the oxytocin system, which seems to be a resilient increaser. We're starting to understand more and more the role of genetics. Addiction is a very complicated disease, and we're not going to find just one gene that is causing addiction, but there are definitely risk factors in the genetics. However, they often interact with the environmental factors. So something that we can do is indeed working on the connectedness. If a drug like meth is the best thing somebody has ever experienced, if they have never found any positive experience in anything that's natural, meth is an enormous temptation. And often it's very difficult for people then to choose other things like family over meth, which they feel is giving them what they need instantly. And I think it's really important to really focus on a good early start. In a broad range of things, give people opportunities to challenge themselves, because challenges help you grow. They give you understanding of what you can do and what you can manage, and they help you to, for example, learn to manage stress. And I think, although we don't, there's so many things involved in the biology of addiction. We know, for example, the stress system is very important in the risks around it. So if somebody is it's not very poor in managing their stress, that's something that you can pick up from your parents quite easily. For example, we know that they are much more likely to use alcohol to manage stressful situations. So if we can get people to have a healthy early environments, social challenges, physical challenges, really develop fully, then I think that helps increase the resilience side of things. And they will always have, they might have trauma, not always, they might have trauma along the way, but they just have more tools to handle it in a healthy way.
Thank you. Linda?
I do systematic literature reviews, so I'm sure the audience will be really amazed to know that I think we should do more. As Femke has mentioned, as we've talked about tonight, addiction is a complex condition. It's this complex mix of psychosocial and biological factors that come together. So that means it can be quite difficult to make sense of the information about what treatment interventions work. So through systematic reviews, we can keep cutting through those issues and cutting through them a different way, looking at things both quantitatively and qualitatively to try and work out how to link together the different interventions, the different supports in a way that addresses the complexity of issues for different individuals.
And a very powerful way of combining smaller studies into a virtual larger study which may have more power to really arrive at a meaningful answer. So thank you. We might now throw the opportunity open to the audience who may wish to raise a specific issue or question. And I think we have people with microphones, so if you want to raise your hand or stand up, we can provide you with microphones. There's one down here.
Yeah, I'd just like to say I was really impressed with the three of you, what you said. And I think over the last 15 or 20 years, Australia has grown enormously in its ability and understanding of how to deal with these issues. I've been involved personally myself because my son had problems. So we lived in Melbourne. We lived in an area where there was a high heroin addiction. At that time, I remember going to meetings with the ALP and trying to encourage a better understanding that perhaps clinics which helped people, and so they took their drugs there rather than go on the streets and use needles and stuff like that, and repeat needles. But I saw some awful, seriously awful violence caused by heroin addiction, and some people coming out of jail and forcing women that they knew and beating them viciously to get their money so they can go and get their heroin. It was terrifying really to see some of that. So I think ice, I don't know if ice falls into that same category, or whether ice is cheaper to buy than heroin, or whether as it compares in other ways like that, or so I don't quite understand ice. That's what I was going to say.
Thank you.
So the price of all drugs changes on supply and demand, and the demand for ice has been relatively high. You can buy a cap for somewhere between $50 and $80 if you know where to go and what to do, and if you don't, you could pay substantially more than that. It's part of the challenge, I think, is that with all drugs, they're commodities that are sold by people who you know. So people who deal in drugs are people that you will form a relationship with, and that if they don't have one commodity, they'll offer an alternative commodity. And often that's been the big problem in changes in drug availability and use, has been the diversity of drugs. So where people who have been in heroin treatment programs in Australia have ended up with methamphetamine problems because the person who was previously selling them heroin has now been selling them methamphetamine. So we've seen that happen in Australia as we've seen it elsewhere in the world. So people shifting between drugs and dependence is also a reality.
Oh, can I just add to that? I think opioids are a very different type of drug than meth. So normally opioids are depressants and meth is a stimulant, but people are indeed quite happy to move between them. But what you describe, it's very interesting. I think a lot of the interventions that we see that work, like injecting rooms, might not be very popular, especially not for politicians, because they feel counterintuitive, like you're condoning use, but they might help get us in contact with people that are using and getting them into other treatments as well. And some of the behavior that you described, what people do to get drugs, I think that's not limited to one drug, unfortunately. It's part of that compulsive drug seeking is that people will do anything to get that drug, and in their mind the choices are very different. When you and I would look at a certain thing, what would I do to get a drug? Well, you think, well, I wouldn't hit my wife or I wouldn't steal, but for them the choices are very clear. I just need this, and that's the only thing that's important, and that's why you really need to work on that, both the physical and psychological sides, because you can't just treat one and expect the rest to just dissolve. Addiction is really, really a very physical experience in that respect, and it makes people do insane things, I think.
Thank you. We have another question up the back.
I'm interested in an approach to schools, because many children in our schools are living in families where either the mother or father is an alcoholic or addicted to other chemicals. On rare occasions, I've managed over the last 30 years to get into schools, but on the whole, the administration in schools is not particularly interested in providing children with means of addressing their own problems. For example, I'm familiar with a case where 2 children in year 11 were watching the film Shattered Spirits, and one child said to the other, "That film is about your family." And as a result, the second child took the initiative to address the problem through sorting out the problem in the family. I think there is a lot of scope for your work and even on a broader scale, to be provided in schools before the problems really emerge, because many children imitate their parents' behaviour, and if mum and or dad is resolving their issues by drinking or taking other drugs, it is not unusual for a child to follow their example.
Yeah, can I comment on that? That's a very fair point. I think a lot of kids, what they see around them, that's normal for them. They don't have any other reference, and if they see that their mum or dad is coping in a certain way, they might copy that, even though they feel that it's not working really well. They might not have other opportunities. They don't see other approaches. And schools are indeed a great opportunity. I think schools are sometimes a bit weary of having you talk about drugs, because they're like, oh, I don't want to get them any ideas in their head. I work with quite a few schools because I do a lot of neuroscience activities with them, and I'm always a bit wary about whether I can talk about my work, about addiction, because it's so ugly compared to all the cute stuff they do there. But a lot of kids have experiences of people struggling with behavioral addictions or other addictions around them, uncles, aunts. Addiction is so common that people have it around them. And sometimes it's a bit of an aha moment when they understand what it is. But for a lot of kids it might be tricky to relate to. So I think there's a really place for specific schools to give information. And something that a lot of schools start to do now is trying to work on getting kids to increase their resilience. So really look at the positive attitudes that they have and try to increase those. So it's not related to addiction specifically, but it's meant to increase their resilience in general. And I think that's also something that schools are a little bit more open to.
Robert.
Yeah, look, I think you speak very nicely to a couple of points that I'd like to make. One is the importance of us as role models. Kids are very good at seeing the difference between what we say and what we do. And if we say and do the same thing, and we are good role models, that actually has a terrific influence on them. So it's something that we can do. Principals decide what gets taught within their school. So even though the South Australian system has got an agreed curriculum, actually content is designed and determined at the individual level. So we as parents have an opportunity to tell our principals what we want in the curriculum, and there is an integrated reception to Year 12 drug education curriculum which has been purpose-built and delivered, but it needs to be taught, and there's a lot of pressure now on kids getting grades to get into places like universities. So we need to also make room for those other important opportunities. The other thing I'd say is that there's also a belief sometimes about the important quick fix. So there's been one-offs, experts, and I'm guilty of this too, going into schools to give a single talk. And I don't think that actually changes things as much as we would like. It needs to be connected to what else the school is doing. So parents and friends associations looking at healthy lifestyles in the school that build into it commitments about drugs is quite important. So there's lots of things that we could do, but it really starts with local action of getting the principals to see this is important and we want it included.
Thank you. Now we have another question over here.
So I have a question about licks, dexamphetamine. What are your hopes of it becoming a substitute medication, and is there any possibility of it coming through the PBS?
Well, our hopes are that it's safe, effective and it works. But until we've done the clinical studies, we won't know that for certain. We've good reasons to believe it's a good medication. Our pilot work convinced us that this is worth doing, but we still need an adequately powered study to see if it does work. If it does work, then the people who make the medication then need to look at its listings on the PBS. So that's a commercial decision that they would make. But if we do the study and show that it works, one would assume that they would then see that as an opportunity.
Thank you. We have a question here.
Yeah, I'm just wondering about ice-addicted mothers having babies, whether those babies are more likely to take drugs later on in life.
That's a good question. There's quite a bit of research on that for a range of drugs. When a baby is, the fetus is in the mother, it is exposed to a lot of things that the mother consumes, whether it's alcohol, smoking, or other drugs of abuse. And it's interesting that we can't always predict which one have the most long-lasting effect. And we really need to look at birth cohort studies, for example, where we follow kids from even before birth and look at what mothers are taking and look at a long-term effect, or even I'm looking at studies that, for example, look at kids that are about 3 or 4, because a lot of the behaviors that, like impulsivity and some of the risk-seeking behaviors might already be present there, although they're not using drugs. So we're really trying to identify what it is, because, for example, we know from smoking that it has very detrimental effect, but opioids in itself, for example, although you would think, oh goodness, opioids have less negative effects, if I'm correct, if you want to add to that.
Yeah, I think that part of the challenge on somebody who's addicted to a drug is actually stabilising them so that their well-being and the unborn child's well-being is looked after. And this is a complicated matter, isn't it, about trying to help them regain control of their life, because we know that connectedness to parent is actually quite important for future development. So we're trying wherever possible to ensure that does happen. It's also important that we realise that not everybody who uses meth is necessarily addicted, and so screening for people who use drugs in pregnancy is quite an important thing. Midwives, obstetricians thinking about it, and then responding appropriately for people who are using and not feeling stigmatised and shamed, so they're less likely to tell people what's actually going on.
Sure.
Yeah, and can I just add to that? I think you hit the nail right on the head. I think we don't know exactly what it does with the developing brain. It's likely that it's not good. It might have subtle behavioral impacts, but that is something that can still affect, for example, schooling or later drug use. But if somebody is an active addict, of whatever kind, it's likely to impact parenting, and we know that has a very long-term impact. However, people that are pregnant or that have little kids might also be more motivated to change than any other time in their life. So it's really an important time to engage with them and to help them manage and to help resolve all the other issues that might be feeding into that addiction, like worries about jobs, finances, everything else. It's usually not that a person is brilliant off and then just addicted. Often there's a lot more, and I think it's really important that we do have that really holistic approach to help people do the best they can at that time.
Thank you. And we have another question here and then one down the front, and then we'll probably wrap up.
Hello. I have a question around the dexamphetamine again. So I'm just wondering how far the research has gone, especially in terms of comorbidity and poly users. Also, I quite enjoyed the articulation of the necessity for step care and integrated therapy. The reality, though, is on the field, on the ground, that's not highly achievable for many services. But again, I reaffirm that my question is around the dexamphetamine and how it works for users with comorbidity issues and poly-use as well.
I think that coexistence of drugs and particularly mental health conditions is a very common coexistence, but it's not the only comorbidity that we see. We see hepatitis C and a variety of other health and welfare coexisting conditions. part of the challenge is that those people may, in the mental health area, may be using drugs to help cope with their mental health conditions. So it may not be the cause of the mental health condition, it may be part of what they think is the solution, and then it brings with it its own secondary set of problems. Colleagues in Victoria have been looking at screening mental health populations using the instrument that I mentioned before, the ASSIST, and that has been successful in identifying people who have problems, and they have been able to respond to those problems. And part of the grant that we've got from the Commonwealth Government is now trying to extend that to be more of a national approach. So this is equipping people to know how to ask the questions, but also what to do with the answers. Having said that, I've also said that we do know that methamphetamine can create mental health problems. Aggression, psychosis, depression and anxiety are common occurrences from people who intensively use methamphetamine. There's a strong biological reason why that happens. Stopping using the drug usually makes those problems diminish or go away. But at the time when you're using, you often don't see the connection. You think they're unrelated and you think the drug is part of the solution rather than the cause of the problem. And that's where it's really quite important that people who come to health and welfare attention are identified and can be moved into specialist treatment services. Making those connection opportunities sometimes requires somebody else to help you connect the dots because you don't actually see them.
Thank you. We have a question here in the front.
Thank you. With that, do we know how long it takes for the brain to reset its production of serotonin and dopamine and things like that after people stop using ice? Is it a longer period than coming off of other drugs? That seems to be the experience. I have a nephew who is incredibly suicidal every time he comes off a binge. And apart from learning how life skills and having support networks and things like that, if life is grey for a very long period, then the chance of relapse is more. Is there any, what do we know about how long it takes for the brain chemistry to reset?
Well, there's been quite a bit of work that's been done on this in the United States. They've used imaging scanning to look at regeneration of neural pathways and for the neurons that create the dopamine and the serotonin to actually regain their stocks. We know that methamphetamine can get into those cells and actually can destroy some of those cells. So not only does it deplete the dopamine, but it can also interfere with the nerve cells that create it. But having said that, change does occur, and regeneration, the brain is remarkable. When I was a medical student, we were told that the pathways were set for life, but that's actually not true. The brain is remarkably adaptive in terms of overcoming problems and rewiring itself, changing the way the pathways operate. Now that takes months, it doesn't take days or weeks. And it's that grey area that you talk about that's quite important. It's about helping people who want to get better but don't have the emotional energy or the drive to create that force to get better. And that's where we can help them by focusing on the positives, helping them see the small steps forward are important steps, and that going backwards doesn't mean give up. It just means what can we learn from that and how can we do it differently next time.
Last question up in the middle there.
G'day.
Sorry,
My question is more specifically about addiction, not ice. And you talked about medications used for, I'm assuming, is more the dependency and the weaning off or managing of the addiction of the substance. But what about medications for therapeutic benefits? And my question specifically is about using psychedelic as a therapeutic minister to fight or to cure the addiction cause.
Like with any medications, we would want those to go through clinical trials to prove effectiveness, and also to demonstrate that there aren't unexpected adverse effects. To my knowledge, there are no good clinical trials of those sort of therapeutic applications of psychedelic drugs. So at this stage, I would say no.
Okay, one last question there.
Thank you, speakers. My question, I think, might have already been hinted to be answered. What critical areas of cortex are destroyed by the drug methamphetamine?
So the areas that are principally involved are in midbrain and in forebrain, and the connection between those two areas, so that's the basic drive area, the midbrain, and the overlying executive function gets disconnected. So it's in those areas, but it goes beyond that. The areas of the brain that are affected are actually quite more substantial and wide-reaching, but those are the two that most scientists have been focusing on. I think Femke did a very nice schematic which showed different areas that are involved in the reinforcing components of the stages of developing an addiction. And I think it is more complicated than we originally thought, and I'm sure if we were here talking about this in a year's time, we will see it's even more complicated, because as we get to know the level of detail of the pathways, I think we understand the interconnection in a way that we didn't before. But those are the two main areas that are affected.
Can I comment on that as well? I think you're right. There's people that are addicted, their brain has a different balance. We really look at it more now that people that are using have an emphasis on pathways that are involved in pleasure and reinforcement, and there is a change away from that and an avoidance of withdrawal symptoms after prolonged use, and more of a role of the stress system. So a lot of the negative effects that people experience during withdrawal are actually as a result of the HPA axis. And we know that, for example, my research with oxytocin really looks at oxytocin is a neuropeptide. It's a tiny player in a world of a lot of players that affect behavior. But it has a very far-reaching impact. For example, we know that oxytocin in a specific type of rodent can reduce the pleasure of methamphetamine, and methamphetamine can reduce the pleasure of having a partner present, and oxytocin. But we know that all these systems interact, the serotonin system, the dopamine system, the HPA axis, the immune system, the autonomic nervous system. There is a balance. And in a healthy person, the balance is one way, and if somebody has very compulsive behavior, it's likely to be different. But there's so many players involved, and they're just getting more on the stage, that we're really trying to understand what are the key players that we need to understand, and how can we get this system to move in that direction to help somebody get in charge of their behavior again.
So we perhaps should finish, but I'd just like to ask all the panel if they wish to add anything. If people are looking to know how to assist someone with ice addiction, do you have anything to add to the information you provided during your presentations or in the discussion?
I guess that the key message is to keep it open. Keep the door open for conversation, keep support options open, concentrate on the positives. It can be difficult for somebody who's got a problem to remember those positives, but reframing things as small gains and steps forward, to me, is one of the key things that's important. Get help. Help is available, whether it's family drug support or the Alcohol and Drug Information Service. You don't need to do it by yourself. Mobilise supports around you, and it's one of the things that I think change is possible. It takes time, and you just need to maintain that support opportunity while that change does occur.
A lot of people who have problems with drugs find it important to be able to talk to somebody who can share the life experience. It happens both in the residential setting, in therapeutic communities where it's the whole treatment milieu of a therapeutic community is around the members of the community being the therapy. And it also happens with the mutual support groups such as Alcoholics Anonymous, Narcotics Anonymous and Smart Recovery, where you can talk to other people who have the same shared life event. You can call on someone who can relate to what you as a recovering user are going through in terms of dealing with cravings or stress, or that life feels very grey. So that's part of the role of those support groups, people who have lived the struggle and who can help share what worked for them, what may work for other people.
And I think the main thing for me is that addiction is common, it's prevalent, so don't be afraid to talk about it and don't feel ashamed to go to a professional to seek advice. Because some family members, for example, might feel responsible for fixing the problem. For professionals, it's very hard to help the user manage their behavior, but as an outstander, you can't fix the problem, but engage in the support that is available.
Thank you. We're out of time, so I'd like to finish now by thanking each of our three presenters for what I think were important and illuminating presentations. Thank you.